Good morning. Thank you very much, distinguished chairman, dear colleagues, ladies and gentlemen. I would like to thank the organizing committee and Medtronic for inviting me to this session and provide you with the update with the current position of renal denervation in the landscape of hypertension treatment. It's very important to stress that hypertension is a global pandemic currently affecting 30% of global world population. Hypertension is a treatable and modifiable risk factor. And if left untreated, uncontrolled hypertension initiates the domino effect and dramatically increases the risk of stroke, myocardial infarction, and over the longer term, development and progression of chronic kidney disease and heart failure. And moreover, the midlife hypertension is a strong risk factor for dementia and Alzheimer's disease. Blood pressure is poorly controlled all over the world, in both men and women. And if you take the entire global hypertensive population, between 50 and 60% of the hypertensive patients are diagnosed. From those who are diagnosed, less than 50% are treated. And very importantly, less than 25% who are actually treated achieve their blood pressure controlled. What are the reasons for poorly controlled blood pressure? An awareness of hypertension. Hypertension is a silent killer. 30% of patients do not have any symptoms, and they don't connect that perhaps headache could be the symptoms of blood pressure elevation. Patient non-adherence. Hypertension needs lifelong therapy, and 50% of patients stop antihypertensive medication within 1 year since drug initiation. Another important aspect is our doctors' roles, clinical therapeutic inertia. Only 1x6 doctors actually intensified hypertension treatment over the visit. Most patients just continue prescribing the same drugs without the blood pressure assessment. Unhealthy lifestyle, it's not only obesity, but from my experience, always is a salt intake and preserved food. And you can't imagine how often when patients cut down on salt intake and preserved food, the blood pressure is reduced and they don't need additional antihypertensive drugs. So in other words, it's responsible for so-called pseudo-resistance. And of course, disparity in healthcare. 2/3 of the global pandemic of hypertension is in low middle income countries. When, of course, the issue of drugs unavailability and drug affordability play a major role in blood pressure uncontrol, and also access to the medical insurance and healthcare system. So just simple blood pressure measurements can prevent this domino effect. And of course, when it's blood pressure control, it translates to the reduction of major cardiovascular events, stroke, heart failure, ischemic heart disease, and cardiovascular death. Excuse me. Oh, sorry. Something went wrong. Can I get to the slides? It's something wrong with the pointer. Is the slide number 6 or 7? I apologize for this. Here we go. It's very important. So the blood pressure reduction is strongly related to the proportionally to the blood pressure decrease. Something wrong. Whether it's related to 5 millimeter of mercury reduction, or 10 millimeter mercury reduction. So the current antihypertensive guidelines, they provide the evidence that the primary goal is to lower blood pressure in the vast majority of patients below 130/80. And when you see this green zone, that I will not use the pointer because it's some issue when moving towards this with the slides. So the vast majority of patients, when you see in this red box, we aim to reduce the blood pressure below 130/80. This is particular to the age until 65. And in those who will order the age of 75, this is the green zone for systolic blood pressure. If well tolerated, we also aim for this blood pressure goal. With the diastolic, it's very easy, between 70 and 80% for the vast millimeter of mercury for the vast majority of patients. However, we don't do attempt to lower blood pressure lower than 120/70 millimeter of mercury. The current hypertensive guidelines recommend the use of well-known antihypertensive drugs. However, these drugs do not suppress all mechanisms underlying hypertension or completely suppress a single pathway, leaving contrarregulatory escape mechanisms that also impact over the longer term for blood pressure control. Renal denervation has generated great interest over the last decade among all device-based therapy. And what is the advantage of the renal denervation? In addition to efferent sympathetic nerve inhibition, which most of the antihypertensive drugs works, renal denervation also targets the efferent renal nerves, which coming from the kidney to the brain and influence the central sympathetic blood pressure control in the brain, which of impact on the target hypertension-mediated organ damage. And our experience is with the patient treated with renal denervation in resistant hypertension, there is sympathetic inhibition after the renal denervation, and this effect is sustained out to 12 months post-procedure. This initial excitement with the renal denervation was cooled down after the publication of the Simplicity Hypertension 3 trial, which fails to meet the primary efficacy endpoint. And what we see on the slide, there was no changes in 24-hour systolic blood pressure measurements between sham-controlled and renal denervation group at 6 months after the intervention. However, we need to point limitation of the Simplicity Hypertension 3 trial. It's very important when we assess the true effect on new device treatment that we don't play with the drugs changes. As what you see, 40% of patients in the Simplicity Hypertension 3 trial have changed this medication before the 6 months, before the primary efficacy endpoint was assessed. The second important issue with this trial was there was 70% did not have proper complete renal denervation. In other words, their kidney were not denervated. Only 19 patients had 2 complete nerve ablation in both renal arteries. Further limitation is that we have over 100 operators in more than 80 centers in the United States. Some of the doctors just performed their first procedure in their life. And in this trial, we didn't have any method to verify the completeness of renal denervation, as you remember from my previous chart with the microangiography assessment and sympathetic inhibition. And what we learned from the Simplicity Hypertension trial to account for this limitation when design next generation trial, also the importance is to perform circumferential nerve ablation and focal nerve ablation, not only in the main renal arteries, but also provide radiofrequency ablation close to the ileum and treat the branches of the renal artery. And we now have robust evidence that renal denervation is effective according to the clinical trials, the second generation sham control trials, who were blinded, not only to the patient, but also to investigators. This trial as an efficacy primary endpoint used 24-hour ABPM. These trials were performed in the presence or absence of antihypertensive medication in patients with uncontrolled hypertension and resistant hypertension. However, in 2018, the European Society Hypertensive Guidelines did not recommend renal denervation until further evidence regarding the safety and efficacy become available. And this document were mainly based on the Simplicity Hypertension 3 trial. Although at the time of publication, these guidelines were already out of date because, as you remember from previous slide, this high second generation trial were published between 2017 and 2022. Therefore, there have been multiple consensus statements on requiring the update on the guidance for hypertension treatment, which included the second generation trial. Therefore, the recent 2023 European Society Hypertension Guidelines, based on this robust second generation trial, recommend renal denervation as a safe and effective adjunctive, meaning complementary treatment option for the treatment of uncontrolled hypertension. This trial and the evidence, the guidelines, use class recommendation B, which we have surrogate measure, we have randomized controlled trials, but B, because there are not outcome study. So now we have turning point to hypertension management. Renal denervation is considered as the third pillar in hypertension treatment, following lifestyle modification, physical activity, reduction in body weight, reduction and cut on alcohol intake and salt, in addition to medication. But if still patient is difficult to control hypertension, we have option to perform renal denervation. And the current statement and recommendation of hypertensive 2023 guidelines is that renal denervation can be considered in patients with uncontrolled hypertension, with GFR above 40, when treatment drug elicits side effect or poor quality of life. The second recommendation for renal denervation is in patients with treatment-resistant hypertension with GFR above 40. But very important class 1 recommendation is that renal denervation should be offered following shared decision-making process, which is key, discussion between patient and doctors, and also should be performed in experienced specialized centers. Most importantly, not only to guarantee the proper patient selection and structured pathway for hypertension assessment, but also experience in the procedure interventional doctors. When you think about the first uncontrolled hypertension, we have, in addition to this second generation trial, pooled analysis show that renal denervation reduced 24-hour blood pressure and also office at 6 months follow-up. Very important aspect, antihypertensive drugs do not cover 24-hour period for blood pressure assessment. Therefore, patient needs to take another tablets on the next day. With renal denervation, we have 24-hour always-on effect in patient in the absence of medication. This is particularly important in the morning hours, where is the morning set, where is the time when more stroke and myocardial infarction occurred. The same effect, what you can see in the renal denervation, demonstrate always-on effect on 24-hour blood pressure reduction in patient in the presence of medication. Very important, from the global registry, we know that more than 30% over the 3-year duration achieve the reduction in blood pressure, and they are in the target zone, meaning the blood pressure is controlled, which impact cardiovascular outcome. We have also long-term experience from Australian and German patients, up to 10 years, that renal denervation reduce the blood pressure 24 hours over the longer term and out to 10 years without adding medication. And actually medication better, what you can see on the bottom, is reduced. What about patients with resistant hypertension? It's very surprising, and it's very nice that when we confirm true resistant hypertension, which actually affect less than 10, around 5% of the entire hypertensive population, as a first-line therapy, what we heard yesterday from Professor Neil Poulter is ACE, ARB inhibitor, calcium channel blocker, and diuretic, because this is the definition if patient is not controlled with antihypertensive drugs, including diuretic, and confirmed by 24-hour blood pressure measurements. As a fourth-line therapy, we can add spironolactone or beta blocker or alpha blocker or centrally acting drugs or renal denervation. What you can see, it's class 2 recommendation. So we have option, renal denervation also as a fourth-line therapy if patients do not tolerate drugs like spironolactone or beta blockers is contraindicated or alpha blocker. Most important aspect is the safety of renal denervation, and we know evidence that there is preserved renal function. From my experience in the renal denervation chronic kidney disease, we know there is slow the progression, but also we know there is some improvements in GFR. So in terms of the renal function, the procedure is safe, and also in terms of the renal artery. Very important aspect, that renal denervation should be done in a shared decision-making process after objective and complete patient information. This is very important, and is highlighted in multiple expert consensus statements that patient perspective and preference is very important when we make decision whether to treat with pharmacotherapy or whether to add renal denervation. And when it's factors which may influence patient decision, and preference could be drugs intolerance. Maybe they can perceive that the high blood pressure is a significant risk factor, or maybe they have some experience to the emergency admission because of the high blood pressure. From the doctor's perspective, could be elevated blood pressure, patient at high cardiovascular risk, and multiple drug regimen. And when patients in Germany or Japan were asking, what would you prefer, rather go for renal denervation add-on therapy, 30% of patients expressed the interest in renal denervation. When you look at the slides, doctors are likely to recommend renal denervation, and you see this green zone, that when it's higher blood pressure level, and also the higher number of medication. This is completely in contrast to the patient preference that the bottom, you can see that they consider renal denervation irrespective of number of drugs and irrespective of elevation of blood pressure. Even they are more prone to go for the renal denervation in the absence of medication. Very important aspect when we talk patient about the risk and benefits. And they were asking multiple questions about the vascular injury, side effect, pain, intervention, duration of defects. That blood pressure reduction was the strongest influence on the treatment choice for patient. And they would accept even small reduction in blood pressure by 2.5 millimeter of mercury in the maximal acceptable risk of 20% of potential vascular injury or side effects. Very important, which was also the limitation of the Simplicity trial, renal denervation should be performed in experienced specialized centers. Why is important? We required a multidisciplinary team, which should include experts in hypertension and the vascular intervention. The multidisciplinary team should be helpful to implement renal denervation in the structured pathway hospital following guideline-based intervention, including proper blood pressure assessment using 24-hour blood pressure measurements, arterial imaging, and also follow-up visit. Data should be provided to the registry and is clear signals to the payers for the reimbursement of the renal denervation. Shared decision-making is crucial before we decide and discuss with the patient what are benefits or risks related to the procedure. And this requires really clear discussion with patient, and we need to incorporate patient preference. In conclusion, as officially recommended in 2023, renal denervation is recommended as a complementary approach in patients with resistant hypertension and uncontrolled hypertension who cannot tolerate blood pressure lowering drugs with eGFR above 40. Renal denervation is safe at the time of the procedure and in the longer term, what we learned from the Global Simplicity Registry, but also from Australian and German experience. In contrast to blood pressure lowering drugs, renal denervation ablates both efferent and afferent renal nerves, which are not targeted with the drugs. And we know also from other trials which are currently ongoing that renal denervation provides cardioprotective and nephroprotective effects in addition to blood pressure reduction by targeting sympathetic nervous system. Thank you very much for your attention. This is my contact details. If someone can you reach? My name is DAGMARA, is other brand in Europe, and my surname is Herring. Thank you very much.